السلام عليكم، ازيكم يا جماعة؟ عاملين ايه الأخبار؟ إن شاء الله معانا محاضرة النهاردة عن محاضرة مهمة جدا عن الابروتش تو بلو بيبي. المحاضرة هيلقيها علينا دكتور سعود بحيدرة. هو اسوشيت بروفيسور اوف بيدياتريك كارديولوجي انترفنشن كونسلتنت، كينج عبد العزيز يونيفرسيتي هوسبيتال. ودكتور سعود أنا اتشرفت بالعمل معاه سنتين في جامعة الملك عبد العزيز. ومن لم يشكر الناس لم يشكر الله، يعني الدكتور سعود ليه فضل كبير عليا في موضوع سكيل، الاهتمام بالتفاصيل في الهيستوري والاهتمام بالتفاصيل في جمع الداتا البيشنت. يعني الموضوع ده فرق معايا جدا في الشغل مع الدكتور سعود، وجميله انا بشيلها له على راسي محي. الموضوع تحول معايا لسكيل، فبعد كده بقيت انفولنتري بعمله. وكان هو ليه الفضل في الموضوع ده، هو وكل كونسلتنت في في مستشفى جامعه الملك عبد العزيز. واحنا كان لنا الشرف ان الدكتور جميل عطى حوالي 5 محاضرات هنا في ايكوبيديا. ودكتورة خديجة مغربي أعطت سلسلة محاضرات عن الأريزميا، والدكتور زاهر. ومعانا النهاردة إن شاء الله دكتور سعود. فممكن يبدأ إن شاء الله مشكورا، وده حاجة تشرفنا.
طيب، السلام عليكم. صوتي واضح يا أحمد؟
تمام، واضح إن شاء الله.
إيه، طيب. طبعا جزاك الله خير على المقدمة الجميلة هذه وعلى الدعوة الجميلة. يعني أحمد زميل عزيز وأخ عزيز. اشتغل معانا صحيح سنتين، ولكن كأنه قاعد معانا يعني فترة جدا طويلة، ما احنا قادرين ننساه زي ما بنقول احنا هنا في السعودية. جزاكم الله خير وأكرمكم الله على هذه الدعوة. طيب، تخليني تشير ولا كيف يا أحمد؟ كان أي
تمام.
شيء؟
أنا فتحت حضرتك ممكن تشير دلوقتي.
طيب، خليني شير السكرين. واضحة كده السلايدز؟
تمام، واضحة إن شاء الله.
طيب، هتكلم على الابروش تو بلو بيبي. للأمانة أنا لما سألت أحمد مين التارجت جروب، كان بيقول لي إنه معظمهم حيكونوا جنرال بيدياتريشن وجزء منهم بيدياتريك كارديولوجي. يعني البيدياتريك كارديولوجي يسامحونا لو كانت سو بيسك فور ذم. طبعا محاضرات البيدياتريك كارديولوجي في السيانوزز والبلو بيبي از توتالي ديفرنت، بيكون فيها ايكوز، فيها باليشن باي كاث، فيها سيرجريز، فيها كده. للجنرال بيدياتريكس actually we always concentrate on their part of managing الانيشال management, الانيشال diagnosis, stabilizing the patient until the help arrive. فاحنا we will go through some basics اذا سمحتوا لي. هنبدأ أول شيء. What is the definition of cyanosis? Everybody knows that the cyanosis is the bluish discoloration of the skin. best notice طبعا على fingernails، ممكن نشوفه في التونيلز والميوكس membranes of the lips and conjunctiva. طبعا متى تبدأ السيانوزيس؟ دائما لما يكون الريديوست هيموجلوبين أو الهيموجلوبين اللي دي اوكسجينيتد حوالي 5 جرام per deciliter طبعا النورمال هيموجلوبين ليفل. Clinically, cyanosis usually appears when the arterial saturation is below 80%, which is corresponding to a reduced hemoglobin of 3 gram per deciliter at capillaries in normal hemoglobin level. لو تلاحظوا دايما بقول في النورمال هيموجلوبين ليفل. ليش؟ الفاكتورز اللي affecting الكلينيكال cyanosis is the arterial oxygen saturation, الهيموجلوبين ليفل، والارتيريو فينوس oxygen difference. في الاكروسيانوزز او البريفرسيانوزز اليوجوالي اللي هو بيجي في السمول بيبيز. why they have it this despite they have a normal arterial saturation, but the problem normal hemoglobin level, but the arteriovenous oxygen difference is about 60%. النورمال يكون 40%. يعني لو اخذنا from at the capillary level from the arterioles والvenous والvenules, it has to be difference بيناتهم about 40%. If it's more than that, then you will be seeing a peripheral cyanosis. This is in a normal hemoglobin level. طب in polycythemia patients زي normal neonate أول ما يتولدوا their hemoglobin might be very high. They have normal arterial saturation, and arteriovenous oxygen difference is about 40%. It's just up the normal. But the problem is إنه الامount of the reduced hemoglobin is about 3 gram. ليش؟ هي نسبة وتناسب. So if you have a normal level, your reduced hemoglobin is, أو deoxygenated hemoglobin, if you want to say it, is low. But if you have polycythemia, then the deoxygenated level is high. In anemia, despite low arterial SAT, normal arteriovenous oxygen difference is normal. But the problem is, and then the hemoglobin level is low. So the problem is to see cyanosis in anemic patient is difficult. Why? Because the amount of the reduced hemoglobin is low. وهي اللي بتورينا البلود discoloration of الكلينيكال blue discoloration. So طبعا كلنا نعرف what are the causes of cyanosis. It's either cardiac or respiratory or methylhemoglobinemias, which is a rare cause of cyanosis. So how to differentiate between cardiac and respiratory causes? As a general pediatrician, I think that, as Ahmed said, I think details of the basics is very important in general practitioners. Why? Because in subspecialties, a lot of people in subspecialties, they just go directly to the details related to their subspecialties. But the problem or the answer to the question maybe is in the general practice. So the history of the disease is very important. Is there a distress or there is no distress? If you have any abnormal cardiac exam. And then the hyperoxygenation test. So what is hyperoxygenation test? The aim is to differentiate respiratory versus cardiac cause of central cyanosis. So if central cyanosis confirmed by a blood gas, so it's not a methylhemoglobinemia, then we give 100% oxygen for 10 minutes at least. And this is, you can be by the rebreather mask. Then we withdraw a blood gas, arterial blood gas. If PO2 is more than 100 millimeter mercury, it's a respiratory cause. If the PO2 is less than 100 millimeter mercury, so this is a cardiac cause. Of course, there is a quick test that always, or a quick screening everybody do. If I have a patient with a low saturation and I give him oxygen, and then the saturation went to 100, so this is respiratory until proving otherwise. The problem, it comes when the patient is borderline. So you give him the oxygen, then the saturation is about 88 to 90, 92. This is not a normal SAT. It's not a very low SAT. So here where hyperoxygenation test rule comes. So what are the most common causes, cardiac cyanosis? Depending always, of course, in pediatrics, we're talking about age. So if it's a neonate, the most common is the DTGA, transposition of great artery. If it's an infant and child, this is tetralogy of followed until proving otherwise. Of course, we are seeing during the practice a lot of complex congenital heart disease, cyanotic, and they present late. And this is for multiple reasons, they cannot access the healthcare system, the family, they are poor, family is not educated, they think this is the normal color, and a lot of explanations. One of the concepts whenever we talk about cyanosis in cardiac patients, we have to be familiar with the ductal dependent and non-ductal dependent lesions. What does that mean? Everybody knows that the ductus arteriosus starts in 6 weeks of the gestation, and it carries about 60% of the ventricular output. So, Ahmed, can you see the arrow moving?
Clear, واضح.
Okay, so this is the right atrium. When the blood reaches to the right atrium, it goes through a PFO, patent foramen oval, جزء منه طبعا, which is about 30% to 35%, goes to the left side and then to the aorta. The remaining goes to the right ventricle to the pulmonary artery. Because of high pressure in the lungs, the blood instead going to the lungs, goes through the patent ductus arteriosus to the aorta. So the patent ductus arteriosus here carries 60%. Why? Because the lung cannot accommodate any blood. And why it cannot accommodate any amount or large amount of blood? Because simply it's a collapsed lung with high resistance. So the blood always moves toward the lower resistant, which is going to be through the ductus arteriosus. So after delivery, the function of this ductus arteriosus is no more needed after the lung inflation and transferring to the normal function. So how the ductus arteriosus is kept open in utero? This is by a high resistance and collapsed lung, low oxygen tension, and the prostaglandin or prostacyclin from the placenta. So once the baby delivered, in the first 12-hour functional closure happen, and this is through the contraction of a smooth muscle and shortening of the duct with some intimal, intralumen intimal folding. Within 2 to 3 weeks, necrosis and hemorrhage occurs, and fibrosis ended by fibrosis, where the ductus arteriosus at that time become ligamentum arteriosum. On echo, this is how does it look like. In CT, if you came a CT, this is the arch This is the isthmus of the R of the aorta, and this is the descending aorta. So this is the aorta coming down. This is the pulmonary valve, pulmonary artery. This is the start of the left pulmonary artery. As you see, we know ductus arteriosus is the connection between the aorta and the pulmonary, especially at the origin of the left pulmonary artery. So this is how does it look like. I think this is the MRI shows with a different angle. So again, aorta, LP, left pulmonary artery, MPA is here, and this is the PDA. In cardiac cath, this is like we are doing a lateral X-ray now. So in lateral X-ray, we see the aorta this way, like a C shape going down. We see the pulmonary artery here, and this is the connection in this area, ductus arteriosus. So what is the use of prostaglandin? Prostaglandin is used to open PDA in ductal dependent lesion. Usually 70 to 80% oxidized in the lung and excreted through the kidney. Half-life is about 5 to 10 minutes. This is why it's a continuous infusion. So maximum effect in cyanotic heart disease, about 30 minutes. In acyanotic, it might reach to 1.5 to 3 hours. The duct start to close after 1 to 2 hours of DCing the prostaglandin. Adverse side effect, of course, apnea, which is occurring about 10% usually appears in the first hour. Gastric outlet obstruction due to enteral hyperplasia, hypotension, fever, flushing, electrolyte disturbance in form of hypocalcemia, hypoglycemia, hyper or hypokalemia, platelet dysfunction, convulsion, and uncortical hyperestosis, which is a rare things to see actually. The dose, as we know, is 0.05 to 0.1 mics per kg per minute, and then reduced according to the effect. And then once we start to reduce, we maintain it between 0.01 to 0.05 mic per kg per minute to avoid the adverse reactions. So just some tips in administering prostaglandin. Again, sometimes that the NICU, they call us, they said we started prostaglandin now like 15 to 20 minutes and there is no effect. Then when you check, you find some mistake in administering. First of all is the preparation. We should make sure that whoever the nurse is preparing the prostaglandin is familiar with the concentration and whatever the rate is running. So because it's different concentration preparation according to each NICU, it has its own policy. This is one thing. The other thing, we are using long lines between the origin or between the pump that contain the prostaglandin and then the line to attach to the body. So this long line, the nurses usually they flush it with a normal saline. Remember, this is a very slow flow medication because of the rate is small. So to reach there from the pump to the patient, it might take like more than half an hour if you did that. So my advice always, you stand with your nurse, ask her to flush the line with the prostaglandin itself. This is two. Second thing, it's better to be through central line, like in usually on unit, they have a UVC, or you put a central line. Fourth thing, which is very important, it has to be alone because it has a lot of interaction. So don't tell me that I'm having an UVC, I'm putting the prostaglandin and there is some dobutamine and dopamine and IV fluid and the medication is giving through that one and the prostaglandin is not giving. Definitely it's not gonna work. Why? Because they are gonna stop it, they're gonna release it, they're gonna, the infusion will be changing, the rate of infusion will be changing with the other infusions. So please, before saying that the prostaglandin is not working, make sure from the preparation, flush the line with the prostaglandin, central line, and alone in the central line without any other medication or fluids. So if we came to cyanotic heart disease, there is a lot of classification for that, but the most common one that is used is either it's a decreased pulmonary blood flow or increased pulmonary blood flow. So decreased pulmonary blood flow makes sense, like the right to left shunt or like tetralogy of Fallot, pulmonary atresia, or ventricular septal defect. So we know that there is no blood going enough to the lung to get oxygenated to come back to the heart. Increased pulmonary blood flow, this is when there is a complete mixing at any level inside the heart with no pulmonary stenosis. And this is the best example is transposition of great artery. So in transposition of great artery, there is a normal pulmonary blood flow or maybe even increased pulmonary blood flow. But the problem, there is a poor mixing inside the heart. This is why the patient is blue. So this is the normal blood circulation. We know that it comes through superior vena cava, inferior vena cava, to the right atrium, to the right ventricle, then the pulmonary artery, and ended in the lung. And this one, we call it pulmonary circulation, and it has a low saturation. Then from the lung comes through the pulmonary vein to the left atrium, left ventricle, to the aorta, and then to the body. And this is a high oxygen saturation. And this is what we call it systemic circulation. So as you see, the aim of the pulmonary circulation is to start from the body and into the lung. So the blood has to end in the lung in the pulmonary circulation. And in the systemic circulation, it has to start from the lung and end it in the body. Understanding this pathophysiology, or this is very simple physiology, it will really help you to understand all the complex heart disease and how the PDA is working. So the ductal dependent lesion is whenever you have, sorry, I will go that back. So whenever you have obstruction in any area in the pulmonary or in the systemic, you have to bypass it. So if I has a pulmonary atresia, then the blood comes to the RV, doesn't reach to the lung. So how I'm going to reach the blood to the lung? It's going to be through the PDA from the aorta to the lung. If I have a mitral atresia, let's say at the beginning of the LV, then no blood will go to the aorta. So how I'm going to reach, how the blood will go to the body? Through the PDA from the pulmonary artery, of course, to the aorta. And this is going to be right to left shunt. This is as simple as that. Or you have a lesion with a poor mixing in the heart, like a TGA, as we said, with no VSD and small ASD. We'll see a better example here. So severe right side heart obstruction, as we said, critical PS, tricuspid atresia, pulmonary atresia, severe left side of the heart obstruction, hypoplastic left heart syndrome, severe aortic stenosis, severe coarctation, interrupted aortic arch. So what we do usually, we do either palliative, usually start with a palliative procedure in a complex heart. If you have unlimited pulmonary blood flow, then we do a pulmonary artery banding. Why in unlimited pulmonary blood flow? Although the patient is blue, the problem, he has a low SAT with increased pulmonary blood flows and heart failure. So he has congested lung, he has this respiratory distress and low SAT. So the best thing to do is just protect his lung and accept lower saturation. If you have limited or absent pulmonary blood flow, then as we said, we have to bring the blood to the lung. Before, the most common thing to use that we saw that the blaloctosing shunt or BT shunt. Actually, it's a systemic shunt, as you see on the picture. From the innominate artery, we put a small tube to the right pulmonary artery. So this is arterial pressure, high pressure to a lower pressure, and the blood will go and fill both branch pulmonary arteries and the lung, where the blood gets oxygenated and comes back to the heart. Now, I think at least for in most of the centers that I know, the standard is what we call it PDA stenting. So instead of opening the chest and putting the patient on bypass machine, and I know some centers in Egypt, they do the BT shunt off pump also, but still it's a cardiac surgery. We can take him to the cath lab within less than 2 hours. We can stent this PDA. I'm not sure if the picture is clear. But as you see, this is the aorta, this is the PDA here, and this is the catheters goes from the pulmonary artery through the PDA. So, and this is the PDA here. This is where the stent was already deployed, and this is how does it look on the X-ray. So this is a PDA stent. This is how does it look. After the first stage of palliation, then second stage is going to be GLEM procedure, which is basically connecting the SVC, superior vena cava, to the right pulmonary artery. We disconnect it from the heart. This is by the surgeon, of course, and they put it to the right pulmonary artery. Then the blood circulation will be from the lower body. It comes to the inferior vena cava to the right atrium to the ventricle. This is the usual pathway. The other pathway is from the right upper body, which is about 35 to 30% of the cardiac output upper body through the superior vena cava to the right pulmonary artery and left pulmonary artery to the lung. And then it comes through pulmonary vein, left atrium again to this ventricle, which will pump the blood to the aorta. And this is how the Glen works. So after that, we will go to the Fontan. In Fontan, we connect the inferior vena cava to the pulmonary arteries through, this is what we call it lateral tunnel now. This is how they are using, putting a tube from outside, diverting the blood, and instead going to the heart directly to the pulmonary artery. So from the upper body through the superior vena cava to the RPA to the lungs, as before, this is the Glenn. And then now from the lower body to the IVC to the RPA and the lung, and then pulmonary veins back to the single ventricle. So by doing Glenn and Fontan, we maintain the aim of the pulmonary circulation. Remember that when I said that the pulmonary circulation starts in the body and the aim is to reach with the blood to the lung. And this is what we have done now here. And then the blood from the lung comes to the single ventricle to aorta and to the body. And this is the systemic circulation. So when we do it, and what is the expected saturation? This is very important, I think, slide in my opinion. Always I confirm with everybody that they should know that. So if you had a BT shunt or a PDA stent in neonate, usually this is the time we do it in neonate, and you should accept saturation 75 and above. If you did the PA band, it can be done at any age if repair not possible and the saturation above 75% to 80%. When you do a Glenn, you do it within 4 to 6 months of age, and usually the expected saturation is 80 to 85. If you did a Fontan, usually we do it after 2 years or more than 15 kilogram, the saturation has to be above 92%. So if you have a low sat here or a low sat here, you should look, why do you have a lower sat? Sometimes it's the pulmonary hypertension, sometimes it's the stenosis in the surgery. There is a lot of things which has to be considered. So now I have a unit who came presenting with cyanosis. Of course, this cyanosis, this neonate could be in the NICU, could be coming to the emergency room, but we are talking about a neonate. Remember, one fact that the PDA start to close at birth and it takes 5 to 7 days. So if you have any ductal lesion, they have to present within the first 5 to 7 days of their life. Of course, we should ensure our ABCs, like the usual airway, breathing, circulation, and then we should go through the history quickly if he has any previous diagnosis. If he has any antenatal history of ultrasound that was showing abnormal heart, or he had done a fetal echo before and they gave him a diagnosis. We have to differentiate between respiratory and cardiac cause. Look for symptoms of heart failure, because severe heart failure or even cardiac shock can present with cyanosis. Of course, this is a neonate. Rule out sepsis and neurological causes like apnea and convulsion. Then you have to go quick examination like dysmorphic features. Is he respiratory distress or not? Vitals is very important. So if you have a dysmorphic feature like a Down syndrome and he came with cyanosis, Down syndrome, 50% of them, they have congenital heart disease. So there is a high risk of having a cyanotic heart disease. Cardiovascular exam, these are some clues like absent or decreased pulses all over, lower limb weak pulses, single second heart sounds like in the TGA, or if you have any loud murmurs. So now, what do I do if I don't have a cardiology? I'm not sure about, let's say in here in Saudi Arabia, we don't have cardiologists in the periphery, pediatric cardiologists in the periphery all the time. I'm sure Egypt is a very, very big country. They do have struggling with these things like any other big countries also. So now I'm in the periphery and I have blue baby and I don't know what is happening. If I had a suspicion, I didn't find any other reason for cyanosis, and I think of cardiac cause, I had to secure 2 IV lines, put the patient on a cardiac monitor, give him 100% oxygen by rebreather mask, give him a bolus of a normal saline, 20 ml per kg over 10 minutes. People, they think that whenever you have a cardiac patient, just go with a mini bolus. You go with a mini bolus if you have a patient with approved or proven congestive heart failure. But if you have a blue baby, 5 ml per kg do nothing. Then this step, which is start prostaglandin on 0.05 mics per kg per minute, this is my own opinion, and I think it's a valid opinion in somebody who is stuck and he has no cardiology. I do understand some of pediatric cardiology, they might disagree, but I'm having a baby who is having a ductal dependent lesion, his PDA maybe is closing. I have to fight with all the weapons that I have. Try to maintain a blood pressure, higher blood pressure, like a MAP of 40 in neonate. Observe for saturation improvement. If you had a if the saturation improved with the bolus, and after starting prostaglandin, give another bolus, because the more that you are raising the blood pressure, the more that you are not flooding the lung, actually increasing the intravascular volume. This will help the PDA to open. And be ready for apnea whenever you start a prostaglandin, please. So now the cardiology has arrived. he will do an echo. If it's a ductal dependent lesion, then continue the same and donate route accordingly. So if it's non-ductal dependent lesion, he did the echo and it's normal heart, there is no cardiac reason. Please shut off the prostaglandin. Just shut off. Ask the nurse, remove it. People, they said, no, we will wean. Why do you want to wean something that you don't need? Just shut it off if there is no cardiac cause and remove it. So if I have an infant and child presenting with cyanosis, then now it's different pathology, different diagnosis. Ensure the ABCs like the usual. You have to ask more history. Is there any respiratory causes like infections, congenital malformations, prematurity, chronic lung disease, aspiration? Is the cyanosis was progressive? Is there any element of congestive heart failure symptoms before reaching to the cyanosis and coming to the emergency room? Past medical history is very important, that include neurological disorder, metabolic, previous attack, diagnosis, etc. Again, you do the same things of examination of dysmorphic feature, distress, vitals, in patient, is patient in shock or not? Because shock patient, they will come blue, especially peripheral cyanosis. CVS, look for the pulse differences, loud S2, ejection systolic, RV heave, because all of this is an abnormal physical signs, and signs of heart failure. So if the patient is shocked, then we do the whole shock resuscitation, fluids, inotrope, etc. If congenital heart disease is suspected, the role of prostaglandin is under question, because most of the literature, they're saying after 1 month, prostaglandin doesn't work actually. And you will be amazed that you might have a patient who's 6 or 8 months of age, pulmonary atresia patient, come to you and he has a PDA which is still open, because it's well known this entity in pulmonary atresia patient, their PDAs might be open until 1 year of age, but it will get stenosed with time. And when they come with a stenosed PDA, then do you start prostaglandin? No, because there is no rule of prostaglandin here. You should accept saturation of 75 to 80 or more. Bolus with the fluid, again, try to maintain higher blood pressure. And here, echocardiography is needed really for diagnosis, because you're stuck. Unless there is some big hint to congenital heart disease, you should ask for the echo. So this is another scenario. If I have a 6-month-old boy, status post BT shunt with desaturation. So as we said, the BT shunt, as you see here, it's a small tube between artery and innominate artery and the right pulmonary artery. We're going to do all the things that we have done before. Adding to it, we will give him a bolus of heparin 50 international unit per kg. Why here we are considering heparin? Because most probably, if the patient has a sudden desaturation, this tube somehow has clot in it or start to get thrombosis, and the only way to help it is to increase the blood pressure, so more flow goes through it. Heparin to dissolve the thrombus, or it's just, remember, this is not a well-formed thrombus. This is just start to clot. So heparin will help with that. So it's very important to do that. And if you find that after giving the bolus and the heparin and everything, and the patient, and before the echo arrive and the saturation start to come, there is no problem of giving another bolus and keep the blood pressure higher. Remember, these patients is with a limited pulmonary blood flow. We call them limited pulmonary blood flow. So they don't go into heart failure with too much fluid. 12 months case of tetralogy of Fallot, not repaired, came with a low saturation. How to manage? We will do everything the same, except that the tetralogy of Fallot, they have a specific presentation, what we call it hypercyanotic spell. In hypercyanotic spell, there is a paroxysm of hypopnea, that rapid deep respiration. Their cyanosis will be increased due to infundibular spasm. It occurs in the morning with crying, defecation, or stress. During auscultation, always you have to hear ejection systolic murmur. If you don't have an ejection systolic murmur in a patient who's proven to be or known to be tetralogy of Fallot, definitely there is a spell. And it may progress to loss of consciousness and sometimes convulsion due to prolonged hypoxia. Remember, tetralogy of Fallot, just to remind you, this is a VSD, ventricular septal defect, overriding of aorta, right ventricular hypertrophy, and pulmonary stenosis. Pulmonary stenosis is not a fixed stenosis. What does that mean, fixed stenosis? Fixed stenosis, when you have a stenosis that does not increase or decrease. I'll give you an example. If you have an aortic stenosis, it's a fixed obstruction. But if you have a hypertrophic cardiomyopathy with the big muscle below the aortic valve, this is a dynamic obstruction. And you know, hypertrophic cardiomyopathy is the reason of the obstructive one is the reason of a sudden death of اللي هم لعيبه الكوره اللي يقول لك فجأة توفى وهو بيلعب كوره because of the في الملعب because of the severe exercise بيصير له obstruction and then it does not open again and then he goes. So how do we manage? لازم نعلم الأهل knee chest position. It's increase the venous return, increase the systemic vascular resistance. We do the ABC. نعطيه morphine injection sub-Q. It will help on decreasing the stress of the baby because of the hypoxia, and it will relax the muscle. We put an IV line and give him bolus of IV fluid. We should correct the acidosis, increase systemic vascular blood pressure, increase the systemic blood pressure. We start beta blocker to relax the heart. If this is failed, then we have to intubate, sedate, paralyze. If it's failed, then he has to go emergency surgery. Usually the full repair at age of 5 to 8 months. And it can be as early as 3 months of age when they close the VSD and they enlarge the pulmonary artery and the area below it. So if I have a neonate came with absent lower limb pulses, so how do you manage? Of course, neonate absent lower limb pulses, the most important diagnosis is coarctation of the aorta at the site of the PDA when the area is very small and it becomes very constricted. So the pressure below is low, the pressure up is high. And of course, if it's a neonate, then we start the prostaglandin and prepare him for surgery and these things. If he is above 3 months, let's say above 3 months, with absent lower limb pulses and it's just a coarctation, we take him to the cath lab and we do balloon dilatation. If you have a neonate, 5 to 7 days came in shock state with weak or to absent pulses all over. What is the most likely diagnosis? I think everybody knows it's a hypoplastic left heart syndrome. When you have mitral atresia, aortic atresia, hypoplastic aortic arch, maybe interruption, maybe severe coarctation, always they have absent. And this is the typical presentation to them. He was a neonate, discharged, comes at 5 to 7 days, gray in color, shock state, absent or weak pulses all over. It's a hypoplastic left heart syndrome until proving otherwise. So this is very important. Always they're taking it to the general pediatrician. If you have a cyanosis, first day of life, with no distress, this is, and no, of course, risk factors, like there is no pre-rupture of membrane, no signs of sepsis and these things. The diagnosis is a detransposition of great arteries. So you started the prostaglandin, and the problem, the patient is still with desaturation. So what do you do? As you know, in transposition of great arteries, the aorta comes from the right ventricle and the pulmonary comes from the left ventricle. So if you came to the circulation, the superior vena cava and inferior vena cava, they will take the blood to the right atrium, right ventricle, to the aorta, and then to the body again, back to the SVC and IVC. And this is a low saturation. It does not have, and this is what we call it, supposed to be the pulmonary circulation, where the blood reach to the lung to get oxygenated. So now it's just become the saturation go lower more and more and more and more. On the other hand, through the pulmonary vein, from the lung, of course, to the left atrium, to the left ventricle, to pulmonary atresia, to the lung, and then back through pulmonary veins. This is very high saturation. But the problem is it doesn't go to the body, so the body does not get benefit. So how can I stabilize the patient? Stabilizing the patient by doing a connection between these two separate circulation. Usually there is a small PFO or there is an ASD or a VSD, of course. But if they don't have, it means that, if you have a cyanosis or low saturation in these defects, it means either the defect are small with restrictive shunting, like the ASD or PFO is very small, or you have another pathology accompanied, like a restrictive pulmonary blood flow. So you have pulmonary stenosis, or you have severe pulmonary hypertension. This is another pathology. So what can I do? The aim now is to maintain acceptable saturation till the patient go to a corrective surgery. So medically, I have to correct the acidosis. I have to give, correct any electrolyte disturbance, start the prostaglandin, as we said, and oxygen administration. One of the big indication to interfere with balloon atrial septostomy is low saturation with metabolic acidosis. Even if I have a saturation, any saturation above 75 is acceptable. But if it's like 75 to 80 with a metabolic acidosis, high lactate, it means this is not good. You have to do the atrial septostomy. So what is atrial septostomy? Basically, we are creating an ASD on the atrial level to allow the blood from the left atrium, which is a high oxygen, to go to the right atrium, which is a very low oxygen, mixing, and then go to the blood. So instead that this circulation on the right side, very blue, it will become less blue with some oxygen to the tissue. So we pass a catheter with a balloon tip, we inflate the balloon, we pull the balloon like we are cutting in the septum, and then you have the ASD. This is how does it look in the echo. So this is left atrium, this is the PFO here, and this is the right atrium. You pull it, the balloon as it is, it comes to here. This is another view. As you see, this is the here. This is the catheter with the balloon, and after cutting it, you created a big hole enough for the baby to live. Surgery, arterial switch operation, and coronary transfer. Basically انا اقول دائما when I say it, just اعكس المعكوس. هم معكوسين، اعكسهم مرة ثانية, they will become normal. 2-month-old infant presented with a pansystolic murmur and cyanosis. How to manage? We will do the whole thing like before. But remember, why did I choose a 2-month-old? Remember, all the left to right shunting lesion, the acyanotic heart disease, the maximum presentation is at age to 6 to 8 weeks. Why? Because at birth, pulmonary hypertension is there. Then the pulmonary artery pressure start to go down slowly until become normalized at age of 6 to 8. And then they might come in a cardiogenic shock. So if you have a 2-month-old, especially 1.5 to 2-month-old, with cyanosis and a pansystolic murmur, don't think of ductal dependent lesion. They think of severe heart failure lesion that caused this thing. Thank you.
ثانك يو دكتور سعود، وندرفul concentrated lecture، محاضرة جميلة جدا، تسلمي حضرتك. طب يا جماعة، في أي أسئلة دكتور سعود؟ أي حد ممكن يفتح المايك ويسأل.
السلام عليكم.
وعليكم السلام ورحمة الله.
أولا شكرا جدا يا دكتور على المحاضرة جميلة جدا. حضرتك لمت لنا كل الديفرنشال دايجنوزس. كنا عايزين حضرتك ما تبطلش كلام يعني بصراحة
الله
من
يكرمك،
جمال
جزاك الله
المحاضرة.
خير. شكرا.
والله. عندي سؤال بس. الله يخليك يا رب. أولا أنا دكتور شيماء، أنا داخلة بس بأكونت بنتي اسمها سلمى. أنا دكتور شيماء كونسلتنت بيدياتريك كارديولوجي ومدرس في طب المنصورة الجديد. كنت بس عايزة أسأل حضرتك في براكتس بتاع الجلين والفونتان، هل حضرتك بترشح نكمل الفونتان ولا نكتفي بالجلين؟ الموضوع ده بصراحة أنا محتارة فيه، لأن أنا كل ما أقابل بيبي عمل فونتان مثلا 6 سنين 7 سنين، أنا بحس إن الدنيا يعني إيه بقت مش أفضل معاه. يعني انا حاسه ان انا بكتفي بالساتويشن بتاع الجلين اللي هو 87 احسن ما اوصل ل 92، لان دايما بحس ان الفونتان بيدخلي في كومبليكيشن بتاعه الهايبو البومونيميا والاسايتس وبحس ان هو بصراحه سفرنج من كومبليكيشن بعد كده هو في غنى عنها يعني. فانا مش عارفه البراكتس عند حضراتكم، هل انتوا فعلا بالشفت للفونتان ولا بتكتفوا بالجلين انا عايزه اسمع راي حضرتك بصراحه
أي
في
دكتورة
الموضوع ده.
شيماء، أهلا. للأمانة لا، إحنا usually we continue to the فونتان. خليني أقول لك حاجة على الفونتان. طبعا لازم نفهم إنه إحنا كلنا البيدياتريك كارديولوجي كلنا متفقين إنه we have a biventricular repair and we have a single ventricle palliation. So we are not giving a full treatment for single ventricle. إحنا we are trying to help this baby or this child to live normally as much as he can from or she can of her life. إيش يعني؟ يعني you will be amazed. I have seen a fontan patient عمرهم 30 سنة 33 سنة and they were living. بس طبعا هل هم living normally؟ لا طبعا. They do have some buffalo obstruction, they do have some ventricular dysfunction على medication, arrhythmia. All of this is complication as you زي ما انت تفضلتي انه في complication تبعت الفونتان. عشان كده في ناس كتير what they do they divide الفونتان patients into two groups. في اللي هو low risk group وفي high risk group. اللو ريسك جروب هم الناس اللي they have good ventricle, trivial AV valve regurg, normal pulmonary artery pressure, PVR is below 3.5 Woods unit. طيب هدول الناس they do فونتان for them. الهاي ريسك فونتان اللي هم البوردر لاين ventricles اللي هم السيستميك، لما يكون السيستميك ventricle is right ventricle، لما يكون في عنده moderate AV valve regurg، لما يكون في high PA pressure، لما يكون ال PVR is 3.5 to 4. a lot of people they deny him surgery. طبعا السؤال هو انا ليه ما اخليه على الجلين؟ خلي بالك
بالظبط.
الجلين هي it's responding about only 35 to 40% من الكاردياك output. with time البلد اللي جاي من الاس في سي ثرو الجلين لللنجز، السات حقه عمره ما حيكون يفضل لغايه ال 80 85. whenever they grow more هتلاقي الساتوريشن بينزل. هتقولي لي طيب بس يا دكتور انا لما بشوف السات حقه ترى بلاقيه 80 78 في العياده which is good. صحيح، لكن جربي خليه يمشي في العياده 5 دقائق وتيك السات، هتلاقي السات حقه اللي هو 78 ده نزل ل 60، وبالتالي البيشنت هي سفرنج. يعني الليمتد، حتى الاهل يبداوا يقولوا والله يا دكتور ترى الاكسرسايز حقه از ليس، مش زي زمان. زمان كان بيطلع دور، دحين ما بيقدر يطلع دور. so then you are pushed to go to the fontan عشان تجيب الساتوريشن 92 provided that we know ترى كلنا انه it's a palliation. you at one of the stages that you will have all the complications of the fontan. انا عارف انه في سنترز كثير they don't believe in high risk fontans، بس في سنتر اكثر they do believe انك act with the things that you have it now. Don't think of the future. يعني أنا مثلا كنت في بدايات البيدياتريك كارديولوجي كنت أقول why we are doing جلين فونتان وإحنا عارفين إنه في النهاية they will be suffering. خلي بالك يا دكتورة الطب بيتغير في كل دقيقة. إحنا
صحيح.
صح؟ فإحنا ما نعرف، يمكن في خلال 5 6 سنوات they might find another solution for them. فهل احنا نضيع هدول المرضى عشان احنا بنقول والله احنا شايفينهم بيتعبوا؟ وزي ما قلت لك it's totally different في الكرايتيريا اللي الناس بتختارها when they are doing فونتان. ان شاء الله
تمام.
اكون
أنا
جاوبتك.
الله يخليك يا دكتور. كنت عايزة آخد رأي حضرتك. طب أنا لو رأي حضرتك مثلا لو بيشنت عمل إكسا كاردياك فونتان وحساه سفرنج، ممكن يكون التشويس بتاع التايمينج بتاع الفونتان ما كانش مظبوط. هل الفينستريتد باي ديفايس ممكن يحسن لي الحالة، ولا الفينستريتد في الفونتان ممكن تزود السفرنج وتبقى ريسك على البيشنت ده؟
الآن this is when do you do fenestration. you do a fenestration لما عندك failing فونتان عنده ascites الليفر له البومين and he's becoming like frequent admitter to the hospital. صح؟ most
صح.
probably. تمام. so انا
بالظبط.
عشان اخفف الميزري هذا I do the fenestration through من الفونتان. طبعا بالمناسبه الفنستريشن يعني انا يعني we have done a lot of fenestrations، بس واحده مثلا من الفنستريشن after we did the fenestration and we stented البيشنت مسكينه جاها CVA and she was suffering from the CVA. طيب so it's
تمام.
not it's not it's not a low risk procedure، ولكن it will release ال high pressure في الفونتان على حساب الساتوريشن. يعني لو هو كان ساتنج 92 الان he will be ساتنج 85 84. بس again زي ما قلت يا دكتوره شيماء it's a palliation. فانا I have
تمام.
to deal with him to improve his quality of life as much as I can. انا I'm not treating him. وهذه يعني اي احد يتعامل مع السنجل فنتريكل زيزو انت الكونسبت هذا جدا مهم يكون عنده، انه انا بحاول احسن الكواليتي اوف لايف as much as
بالظبط.
I can and deal with the complication.
تمام. بشكر حضرتك جدا، وعايزة اخد وعد من حضرتك ان دي مش تبقى اخر محاضرة، وان احنا مستعدين نسمع حضرتك كل يوم جمعة، يعني عادي.
الله
مش
يديك
مشكلة.
العافيه، قول ان شاء الله نرتب مع احمد ان شاء الله.
يعني احنا كل يوم جمعة ممكن نثبت حضرتك،
الله
يعني
يديك
تبقى
العافيه، نشوف كيف ان
شيء
شاء الله دكتوره
تبقى
شيماء.
شيء اساسي، يعني يبقى والله جزاك الله خير، يعني بجد مبسوطين جدا.
الله يكرمك دكتوره شيماء، انت من المنصوره بتقولي صح؟
انا من المنصورة، يا فندم.
مع منى وجيهان.
مع دكتورة منى وشغالة مع
غريبه
دكتورة هلا.
ما شفناك، احنا جينا مرتين ترى.
لا، انا جيت على فكرة، بس مش عارفة ممكن حضرتك، انا جيت مرة واحدة بس قابلت دكتور جميل.
اوكي تمام، اهلا نتشرف
بس
بك يا دكتوره.
شكرا جدا، والله مبسوطة جدا، يعني والله
الله يديك
بجد
العافيه،
شكرا
اهلا دكتوره
جدا.
شيماء تفضلي.
ربنا يبارك فيكم يا رب.
شكرا.
في أسئلة تانية يا جماعة؟ طب أنا عندي سؤال يا دكتور سعود.
ايه تفضل يا
ساعات
حبيبي.
في بيشنت بيجي بيبقى داكت بنتنت وبيبقى ليت دايجنوز او بريزنتد، يعني ساعات بنشوف بيشنت انتربت اورتيك ارش وهو عنده مثلا 3 شهور، او بالمونة
امم
اتيزيا تاكت بنتنت وهو عنده شهرين 3 شهور. هل في كات تايم للبروستين؟ يعني بعده خلاص يبقى البي دي اي غالبا مش هتتقفل لوحدها، فمش محتاج بروستين.
ايوه، زي ما قلت لك كل الداتا بتقول انه بروستاجلاندين افتر فيرست ويك اوف لايف، افتر فيرست 4 ويك، يعني بعد شهر does not work للامانه. سو يعني بمعنى، خليني اقول لك بطريقه ثانيه، انت واحد عمره شهرين وجاك الطوارئ بلو، وهو عنده بي دي اي ان ستينوز بي دي اي، صح؟
تمام.
ايوه، هذه البي دي اي مش هتقفل بكره ولا بعده. it will take a time to close، مش زي البي دي اي تبع اللي دوبه اتولد اللي بتقفل في 5 7 ايام. فهذا انت you have to what you can do is الاي بي سيز وكده and push him with a fluid. تمام. just to
تمام.
maintain البي دي اي هذه as much and then it has to go for surgery as soon as possible. لانه هنا ما في اي ريسك، ما في اي حاجه ممكن تسويها للبي دي اي. طبعا في الاكستريم اللي بيسووه، يعني انا مثلا اكون، يعني انا متاكد عندكم في مصر في اماكن فيها انترفنشنست بس ما فيها كاردياك سيرجري. تمام.
تمام.
فايش يعمل الانترفنشنست؟ يدخل and he stent البي دي اي هذه، بس he doesn't stent it for life. he stent it بس عشان يقدر ينقل المريض او يرتب مع الزملاء في مراكز تانية عشان يروح يتعامل.
تمام. تمام. شكرا، جزاك الله خير. في اي اسئله تانيه؟
السلام عليكم.
عليكم السلام ورحمة الله.
اتشرفنا بحضرتك جدا واستمتعنا بالمحاضرة العظيمة دي يا دكتور.
حياك الله.
تسمح لي بس، هو عندي سؤال ادفانسد شوية. ايه افضل فيو اقدر اتابع بيه الجلين والبيتي شنط؟ يعني لان هي احيانا
دكتورة
بتيجي.
معلش سامحيني، الصوت كأنه ضعيف شوية، تقدري ترفعي صوتك شوية؟
السلام عليكم.
ايوه كده كويس، سامعك،
حضرتك
تفضل.
سامعني تمام؟
اي.
ايه افضل فيوز بالايكو اقدر اتابع بيها الجلين والبيتي شنط؟ لان هي احيانا بتبقى ديفيكولت جدا في السكريننج والفولو اب بتاعها. وامتى اقلق لما تبقى دايمتر كام والبريشر عليها كام لو انا لقيتها؟ ولو انا ما عرفتش اشوفها كويس او اقرر كويس، هل اعمل انترفنشنال ولا سي تي علشان اطمن عليها؟
تمام. سو بيسكلي انت كأنه سؤالك بتقول احنا الى متى نقدر نتابع الجلين والبيتي شنت باي ايكو، صح؟ فهمتك كده صح؟ وايش
مش بس
ايوه.
الاوبتيمال فيو.
ايوه
لان احيانا
وبعدين.
بتبقى انا ما ببقاش عارفه الجراح بالظبط كان فين، يعني علشان احيانا بتبقى فعلا difficult ان انا اطلعها بالاكس.
اي بس هو شوفي يا دكتوره، طبعا اتس عاده البي تي شنت طالعه من النومينت ارتري، بعضهم يطلعوها من الكاروتيد. بس هو انا عشان ادور على بي تي شنت، انا ما اقول اتس امبوسيبل، بس تقدر تلاقيها عاده نجيبها من السوبراستيرنال اريا. اذا ما شفتها في اليوجوال بوزيشن في النص، اي موف البروب، اجيله من اليمين او من اليسار looking for any turbulent flow، لانه احنا عارفين البيتي شنت is a very turbulent flow. So basically يعني عاده في البوست اوب احنا دائما نقول للمرضى لازم يكون معاك تقرير العمليه، لانه في الكومبلكس كونجينيتال للامانه ما نعرف ايش سوى الجراح. خليني اقول لك حاجه ببساطه مره شديده، ام شور انك يفيس، لو كان عندك توتال انومالس بالمونري فينس درينج مثلا، طيب، وجيتي تبي تعمل ايكو، طب هو التوتال انومالس هذا هو كيف هاو ديد هي ريبير هيم؟ هو كونفلونس وفتحوا على الليفت اتريوم، ولا هو كان جهه حطها على الليفت اتريوم وحاجه حطها في الابندج؟ اتس ديفيكولت بدون ما يكون عندي سيرجيكال ريبورت. سو احتاج انه دائما يكون عندي تو نو البيشنت حقي يكون معاه الاوبراتيف نوت حقته، هذا واحد. الشيء الثاني طبعا البي تي شنت دائما عليها جريدينت. whenever you have a low gradient على البي تي شنت you should think of obstruction. ليش؟ او طبعا severe pulmonary hypertension، لانه هي جايه من ارتري الى فيري لو سيركيوليشن، لو بريشر سيركيوليشن which is the pulmonary بدون فورورد فلو. فبالتالي البريشر لازم يكون الجريدينت الاكسبتبل، بيقولوا somewhere between 55 to 70 75. whenever you have a very low pressure you should think of obstruction or pulmonary hypertension. هذا واحد. اثنين، it has to be a turbulent flow. اول ما بتصير laminar flow في مكان معين منها، معناته أنا I have to think of obstruction or thrombosis. بالنسبة للجلين، طبعا الجلين it has to be a low pressure، نحط عليها السي دبليو لازم يكون المين حقها less than 3 or 4، ودائما لامينر. الديامتر does not make a difference with me إذا ما كان فيها clinical indication. إيش يعني؟ طبعا احنا خلينا نتكلم كده بشفافية شوية. يعني انا always I tell الفيلوز تبعيني احنا البيدياتريك كارديولوجي we are not echocardiographer، تمام؟ احنا physician. يعني بمعنى انا اي دو ريفيوز لما يجي البي اي سي يو بيدياتريك اي سي يو يقول لي انا عايز ايكو للمريض ده، انا ماني ايكو كارديوجرافر. يو هاف تو تيل مي واي عشان تو انسر يور كويستشن. فهو انا لما يكون عندي مريض بيتي شنت وعندي جلين، انا اي سي هيز ساتوريشن somewhere above 80 85، واكون انا ماني شايف البي تي شنت مثلا، شايف بدايتها بس مش شايفها كلها because of a limitation of echo. طبعا انا مو معقول اودي المريض للقسطره وللسي تي فور نو ريزن. يعني لو البي تي شنت هذه فيها مشكله his saturation has to be low. هذه النقطه الاولى. النقطه الثانيه بتاعت الجلين، اذا انا شايف الجلين وفلوينج وعليها كونستريكشن بس البيشنت ما عنده اللي هو احنا بنسميه اللي هو اس في سي سندروم، اتس نوت اوبستراكتد، ما عنده دايليتد فين، ما عنده هيدك، ما عنده بافي ايز، شايف انه في اللامينر فلو الجريدينت از 4 بس الاريا صغيره، في اريا اللي هو الكونكشن مكان الاس في سي مع الار بي اي شويه صغير، اللي فوقه حجمه كويس واللي بعده حجمه كويس وفيلينج everything، اي ثينك اتس فاين. متى نخاف يا دكتوره في الجلين بالذات والبيتي شنت؟ طبعا كلهم بيتعاملوا في ايج يونج، واليونج ايج دائما الفيوز حقتهم كويسه. لما انا اشوف من بعد العمليه وهو يجيني المريض ويجيني وانا ماني شايف ليفت بالمونري ارتري، مش شايف ليفت بالمونري ارتري اولويز، صحيح السات كويس بس I have to make sure انه الليفت بالمونري ارتري حقه هذا بيكبر. طبعا this is for example، تمام؟ وقتها it depends on your institute. Do you take him to cath ولا CT؟ يعني انا I prefer CT contrast، حيورينا كل حاجه. ما يعني I don't need to take him to invasive procedure. طب انا ما عندي somebody to do the CT for me بس عندي interventionist he can do، then I send him to interventionist. You have to prove انه اللنجز البرانش بي اس بتكبر او بشوفها على الاقل مره every now and then. ليش؟ لانه لما اجي على وقت الفونتان واي مست ال بي اي ده صغير، this become now instead of a routine fontan it will be a high risk fontan، لانه واحده من الكرايتيريا حقت الفونتان تو بي لو ريسك انه لازم يكون adequate branch pulmonary arteries. اي هوب انه انا جاوبتك. انا عارف انه هو الكلام.
شكرا لحضرتك، شكرا جزيلا. اصل سبب السؤال لان احنا معلش في مصر مش كل السنترز بنعمل فونتين، وفي بعض العيانين بيجوا لي كبار، يعني مش يونج ايج، مش الفيرست يير ولا السكند، ممكن حتى ممكن تبقى 10 و15 ولا يعني، فبيبقى كمان الموضوع بقى كومبلكس اكتر، الفيوز اصعب، مفيش previous report of surgery or echo. ف ومطلوب منا ان احنا ممكن نحاول نطلع ريبورت وفي ديسيجن يعني. فعشان كده انا بسأل هاو اند نيكست ستيب يعني. وشكرا جزيلا لحضرتك، فعلا يعني استفدت
اهلا يا
كتير.
دكتوره، الله
ميرسي،
يحييك.
ميرسي لحضرتك، شكرا.
حياك الله، اهلا وسهلا.
شكرا يا فندم، جزاكم الله خير.
تمام، شكرا دكتور سعود، جزاكم الله خيرا، محاضرة روعة، وإن شاء الله ما تكونش آخر محاضرة إن شاء الله.
ان شاء الله، الله يديك العافيه ان شاء الله.
إن شاء الله بإذن الله.
اذا الجماعه، يعني انا شايف شكله بيدياتريك كارديولوجي كتير ترى. احنا وي كان جو سو ادفانس يعني على الباليشن بالكاث بصور سي تي، صور ايكوز، وي هاف ا لوت اوف كيسز. اذا الجماعه حابين يعني بيني وبينك بعدين انت شوف كده ايش اللي تشوفوه. يعني زي ما قلت لكم انا
طبعا حابين أكيد.
this is very basic يعني كلها معظمها كانت جنرال pediatrician thing. والناس اللي بتسأل ما شاء الله they are cardiologists و they know what they are doing. فيعني ممكن نجوز a little bit advanced انه how to close يعني بعض الحاجات اللي ممكن نسويها، مثلا انه الفي اس دي كلوجر. عندي محاضرة اوف هاو تو تشوز ذا ديفايس وايش الكرايتيريا وين ان هاو، وفيها كليبس كثيره وصور حلوه. احنا الكارديولوجي صراحه نحب نتفرج على ايكو كثير ونتفرج على انجيو كثير. متاكد
نتمنى
انه
نتمنى نتمنى يا دكتور والله بجد حقيقي.
عايزة
هذا في كل
أقول
يا
مكان.
ريت والله يا فندم.
نتمنى بالذات لو كاس يعني حقيقي يعني.
طيب خلينا نشوف مع احمد ان شاء الله نرتب المحاضره هذه ونقدمها ان شاء الله. ابشر.
تمام ان شاء الله. وانا ما
بس
قلت لحضرتك ان معظم العدد جنرال بيدياتريشن، بس هو احنا معانا عدد كتير جدا بيدياتريك كارديولوجيست، لان هو الجروب فيه ما شاء الله يعني 14,000 طبيب.
ما شاء الله
فعدد برضه
تبارك الله، الله
البيدياتريك
يخليك.
كارديولوجيست كتير جدا معانا ان شاء الله. فبرضه لو حضرتك طبعا وقت حضرتك يسمح بمحاضرات بيدياتريك كارديولوجي، اكيد الكل هيكون مرحب وعدد كبير هيكون مرحب ان شاء الله.
طيب ان شاء الله خلينا على تواصل ان شاء الله يا احمد. تمام.
ان شاء الله على التواصل ان شاء الله.
ماشي
ماشي،
الحال.
جزاكم الله خيرا وشكرا لجميع الحضور، ونشوفكم على خير ان شاء الله.
يلا جزاكم الله خير على الاستضافة، شكرا لكم.